Welcome back to the deep dive. Today we're really getting into mitral stenosis.
That's right, a key topic.
Think of this as your focused session on, understanding this specific heart condition. We've pulled the key stuff from detailed revision notes for you.
Yep, aiming for clarity.
Our mission is simple. Give you a clear, concise, and hopefully really memorable understanding of mitral stenosis. Boost your learning efficiency.
Let's do it. So, mitral stenosis, basically, it's a narrowing. It blocks blood flow through the mitral valve.
That's the valve between the left atrium and the left ventricle, right?
Exactly. And this narrowing, this obstruction,
Yeah.
it makes the pressure build up, particularly in the left atrium and the pulmonary artery, especially when the heart's beating faster.
And that pressure backup,
Yeah.
it has knock-on effects, doesn't it?
It really does. That high pressure in the lungs, the pulmonary hypertension, it can strain the right ventricle.
Leading to dilation,
And
maybe tricuspid regurgitation.
precisely. And potentially, down the line, right-sided heart failure. You'd see signs like a raised JVP.
That jugular venous pressure.
Yeah, that's the one. Plus liver congestion, maybe ascites, peripheral edema, the classic signs.
Okay, but here's something important to note. If it's just mitral stenosis, the left ventricle itself, its function can stay normal.
Surprisingly, yes. Initially, LV function and overall cardiac output can be maintained.
Huh. But that static blood in the left atrium? That's a risk.
Huge risk. Thromboemboly. Blood clots forming, especially if the patient also has atrial fibrillation. That slow flow is dangerous.
And it often doesn't happen in isolation, does it? Sometimes seen with other valve issues.
Often, yeah. Tricuspid regurgitation is a common partner. But zooming out, the biggest cause, like the overwhelming cause,
Rheumatic fever.
rheumatic fever, accounts for something like 95% of cases.
Right. So rheumatic heart disease following rheumatic fever is number one. Let's dig into the other causes, though. What else is on the list?
Well, beyond rheumatic fever, you can see it from congenital issues, things like parachute mitral valve or Ludenbacher's syndrome.
Okay, congenital.
Then there's degenerative calcification, usually in older folks, calcium just building up.
Makes sense. Anything rarer?
Yeah, a few things. Inborn metabolic disorders like Hurler or Anderson-Fabry. Systemic diseases can do it too. SLE, rheumatoid arthritis, carcinoid syndrome.
Wow, quite a list.
Even things like infective endocarditis if you get large vegetations. Or amyloid deposition in the valve. So yeah, rheumatic fever is dominant, but you need to be aware of these others.
Got it. So risk factors. The main one is clearly that history of rheumatic fever or rheumatic heart disease.
Absolutely. That's the strongest predictor.
And the trigger for that is often those recurrent strep infections.
Yeah.
Right? Tonsillitis, pharyngitis.
Exactly. Which ties into environmental factors, too. Things like overcrowding, poor healthcare access. They increase the risk of rheumatic fever itself.
And there's a gender link?
There is, yeah. Mitral valve involvement seems to be more common in females, particularly with the rheumatic cause.
Okay, let's switch gears slightly to the pathophysiology. What's actually happening mechanically?
So, the narrowed valve, the stenosis, it restricts the left ventricle filling during diastole. That's the heart's relaxation phase.
So less blood gets through.
Right. And that immediately forces the pressure up in the left atrium. And because the left atrium connects to the pulmonary veins, pressure rises in the lungs too.
And the left atrium tries to cope.
It does. It enlarges, it hypertrophies, trying to handle that increased pressure and volume. But eventually, that high lung pressure leads to pulmonary congestion. That's where symptoms like breathlessness come from.
And if it keeps going, that pulmonary pressure.
That's when the right side of the heart starts to feel it. The increased workload can cause right-sided heart failure over time.
Okay. Now, differential diagnosis. What else might look like mitral stenosis?
Good question. You need to think about other valve issues, obviously. Mitral regurgitation, aortic stenosis, even tricuspid stenosis.
Right.
But also things like a left atrial myxoma that's a heart tumor that can obstruct flow. Or primary pulmonary hypertension.
Or HOCM, hypertrophic cardiomyopathy.
Yeah, HOCM needs to be on the list too. So ruling these out is key.
Thinking about the UK specifically, the prevalence has dropped.
It has, thankfully. Better healthcare, antibiotics for strep throat.
Yeah.
It's made a difference. But it's still fundamentally linked to that history of rheumatic fever when we do see it.
And when does it usually appear?
Typically manifests in the 30s and 40s. And again, that female preponderance for rheumatic MS holds true in the UK as well.
All right, clinical presentation. This is where those exam mnemonics come in handy, right? Auscultation. Oscar.
Exactly. Oscar is great for the murmur. Opening snap, followed by a mid to late diastolic crescendo and rumbling murmur. Best heard at the apex.
Opening snap. Then the rumble. Got it. And it's clearer on expiration.
Yes. And you'll often hear a loud first heart sound, S1. Sometimes you can even feel it as a tapping apex beat.
Does anything make the murmur louder?
Hand grip tends to accentuate it. And listen for the pulse if it's irregular, suspect atrial fibrillation.
Okay. Other sounds.
You might hear end inspiratory crackles if there's pulmonary edema. And if pulmonary hypertension is significant, the P2 component of the second heart sound will be loud.
Beyond listening, what signs should we look for? Signs of enlargement.
Yeah. Look for a malar, flush those rosy cheeks. A raised JVP is common. The apex beat might be shifted left. And you could feel a right ventricular heave, like a lift on the chest wall.
And the patient's symptoms, what do they typically report?
It's often gradual, worsening shortness of breath, especially with exertion dyspnea. Then maybe orthopnoea, breathlessness lying flat.
PND. That's sudden nighttime breathlessness.
PND, yes. Palpitations are common, often from AFib. And sometimes Haemoptysis, coughing up frothy, blood-tinged sputum.
Right. And for right-sided heart failure signs, there's another mnemonic. JLEP.
That's a useful one. Jugular venous distension, liver enlargement, hepatomegaly, edema peripheral, ascites, and pulmonary hypertension driving it.
So key signs to nail down: loud S1, opening snap, the diastolic rumble, potential AFib, and those signs of right ventricular failure.
Exactly. Those are the headline findings.
Okay, investigations. What's the absolute cornerstone?
Echocardiogram, no question. It's crucial. It shows you the valve structure, how it's moving or not moving well.
And Doppler tells you how bad the narrowing is.
Precisely. Measures the severity, the valve area, estimate pulmonary artery pressure. It's also key for deciding if someone's suitable for a balloon procedure.
What about TE, the transesophageal echo? When do you use that?
Usually if the standard transthoracic echo, TTE, is unclear, or specifically if you need a really good look at the left atrium for clots before an intervention.
Okay. What else? Chest x-ray?
Chest x-ray can be helpful. Might show left atrial enlargement, a double shadow. Could show signs of pulmonary edema, like curly B lines. Sometimes you see valve calcification.
Yeah, ECG.
ECG is useful for detecting atrial fibrillation, obviously, or signs of right ventricular hypertrophy strain patterns.
Cardiac cath. Is that common?
Less so now with good echo. It's usually reserved for specific situations like discrepancies in findings or detailed pre-op planning. Maybe dynamic exercise testing, too, if symptoms don't seem to match resting severity.
So the main message is, echo is central. TTE is the workhorse. TE has specific roles. And if you suspect valve disease...
refer to cardiology. Definitely.
Right, let's talk management. What are the main approaches? Medications first.
Meds are mainly for symptoms. Diuretics can help with fluid retention, that pulmonary congestion.
Beta blockers.
Beta blockers can improve exercise tolerance, slow the heart rate, give the ventricle more time to fill, and crucially, anticoagulants if there's atrial fibrillation. Warfarin, usually.
And interventions.
Yeah.
When do you step in more actively?
If symptoms are significant or the stenosis is severe, the main options are percutaneous mitral balloon valvotomy, basically stretching the valve open with a balloon.
But only for certain patients.
Yes, the valve anatomy has to be suitable, no heavy calcification or significant mitral regurgitation. The alternative is surgery, either mitral valve repair as possible or replacement.
And everyone needs follow-up.
Absolutely. Regular clinical checks and echo monitoring. NICE guidelines suggest echo every 3-5 years, even for mild stenosis, and more frequently for moderate or severe.
The guidelines also mention beta blockers for moderate severe with heart failure symptoms and push for that transcatheter valvotomy if it's rheumatic and severe and suitable.
Right. Reserving surgery if the balloon isn't an option or fails. Even asymptomatic patients with significant stenosis need close watching.
So medical therapy is about symptom control.
Mm-hmm.
Diuretics, nitrates for breathlessness, beta blockers, anticoagulation for AF or clots, managing the INR target carefully, especially with mechanical valves.
Exactly. INR target 2 to 3 usually, but maybe 2.5, 3.5 for mechanical valves. And controlling the heart rate in fast AF is vital too.
And the intervention choice depends heavily on severity and symptoms.
It does. Mild stenosis, maybe less than 5 millimeter G gradient, valve area over 1.5 centimeters squared. Probably no therapy needed, just monitoring.
Asymptomatic but severe, so gradient over 5, area less than 1.5.
That's where you might consider balloon valvotomy if the anatomy is right to prevent future issues, but definitely if they're severe and symptomatic.
Then intervention is needed.
Yes. Balloon valvotomy, PMC, if suitable, or surgery, either chemisterotomy or replacement, plus diuretics for symptom control. Valve replacement brings its own choices, mechanical versus bioprosthetic valves, lifelong anticoagulation needs, etc.
Okay. What about prognosis? How do people do?
It varies a lot. If you're asymptomatic or have minimal symptoms, the outlook is actually pretty good. Decent 10-year survival.
But if it's symptomatic and untreated,
Then the prognosis is poor. Much lower 10-year survival. And if severe pulmonary hypertension develops, that's a really bad sign. Means survival can be less than 3 years.
so untreated severe MS is serious. Progressive heart failure, clots.
Pulmonary embolism infection, yeah. Treatment, whether balloon or surgery, definitely improves the prognosis significantly. But life expectancy might still be somewhat reduced compared to the general population because of potential long-term complications.
Makes sense. Prevention. It really comes back to rheumatic fever, doesn't it?
Primarily, yes. Preventing rheumatic fever in the first place through proper antibiotic treatment of strep infections is key. And preventing infective endocarditis in susceptible patients is also important.
And finally, complications. We've touched on many, but let's list the main ones.
Sure. Atrial fibrillation is very common. Pulmonary hypertension leading to...
Right-sided heart failure.
Yep. Infective endocarditis is a risk on the damaged valve. Thromboembolism, those clots traveling. Haemoptysis. Pulmonary edema. And even recurrence of rheumatic fever if there's another strep infection.
Quite a list. So, to wrap up, mitral stenosis. It's that obstruction, that narrowing, most often linked back to rheumatic fever.
Remember Oscar for the Murmur. Understand the pressure dynamics, the backup into the atrium and lungs, the strain on the right heart.
And management involves symptom control, anticoagulation for AF, and then interventions like balloon valvotomy or surgery for significant disease.
Exactly. Understanding the whole pathway from cause to complications is key.
It really underscores the long-term impact infections like rheumatic fever can have on the heart, years down the line. Makes you wonder, what other unexpected long-term links might exist between various illnesses and cardiac health? Something to think about.
Definitely.
For more detailed revision and exam practice on this and other topics, do check out pastthemsra.com and freemsra.com. Thanks for joining us on the Deep Dive.